700 and something in each one. And in a nutshell, the main results is that after 48 weeks, in an intention to treat exposed analysis, that means including all subjects that were exposed at least to one dose of the drug, non-inferiority was shown for the dual therapy strategy. So this is the first time that a study shows non-inferiority in dual therapy compared to triple therapy using an integrase inhibitor as the background drug. Prior studies that we also were part of have shown this non-inferiority, but using protease inhibitors, which are very strong drugs, but they carry the backpack of having, drug-drug interactions and tolerability issues, which is not the case of dolutegravir, as all the other integrase inhibitors is a very clean drug in terms of tolerability. It's a very potent drug and with a very high genetic barrier. So we are very pleased to show these results in just a couple of minutes and put it in front of the consideration of our colleagues.
So I see we have got a little bit out of order, but that's okay. We're going to go to Mariana, if that's okay. Our next speaker is Mariana Villosa Morales of the Ministry of Health of Brazil. She's going to discuss the results of a large real-world cohort study looking at the comparative effectiveness of a 3-drug dolutegravir-based regimen. So TDF plus 3TC plus DTG. This study is important because many countries have either changed to DTG-based regimens or are considering doing so. So Mariana, your comments.
So the objective of our study was to compare the observed effectiveness of first-line ART regimens in people living with HIV aged 15 years or older in Brazil regarding the initial virological response to treatment. To do so, we used databases from the Brazilian Ministry of Health, which gathered data on ARV dispensations and on CD4 and viral load counts. So on the background, there have been 2 recent adult guidelines in the country. One was released in late 2013 when Brazil implemented a treatment for all strategy, meaning the recommendation to initiate ART in all people living with HIV regardless of CD4 count or clinical stage. In these 2013 guidelines, lamivudine tenofovir efavirenz, TLE, was the preferred first-line treatment. In early 2017, new guidelines were released, and dolutegravir replaced efavirenz in the first-line treatment. So in our study, we included patients who started ART from 2014 to June 2017 to include patients who started treatment after the treatment for all strategy was implemented. So our outcome was the 6-month virological suppression using a threshold of 50 copies, and our study variable was the ART regimen. We controlled for sex, age, CD4 and viral load counts at ART initiation and adherence level. And then, so the study included around 103,000 individuals, of whom around 68% were males. Overall virological suppression was 76.9%, varying among regimens. 74% of patients on the study started on efavirenz, on TLE, 7% on TLD, and 19% on other regimens. So our most important result was the superiority shown by the regimen containing dolutegravir. It was the most effective treatment, showing 42% higher odds of virological suppression than the regimen with efavirenz, and up to 162% higher odds than the regimens containing protease inhibitors. So then, to conclude, we believe our results support the decision made by the Brazilian Ministry of Health in 2017 to switch its recommendations for first-line treatment from efavirenz containing to dolutegravir containing regimens.
Thank you, Mariana. So we move back to Rebecca Zash of the Beth Israel Deaconess Medical Center. Rebecca will be presenting today data from Botswana that has detected, and I think many of you in the room may have heard about recent signals that have gone out concerning the report of birth defects linked to early use of dolutegravir during conception. And preliminary data from this study has led some of our agencies to put out guidance, and so we are eager to hear what the latest update is after you, Rebecca.
Thank you. Thanks for this opportunity for me to discuss this APAMO study, which is funded by NICHD, where we found this possible association of neural tube defects among infants of women who were taking their dolutegravir starting before pregnancy. I think it's important to understand neural tube defects, which are severe birth defects of the spine or the skull, happen very, very early in pregnancy. The risk is really over by about 28 days after conception. So drugs that cause these defects are almost always started before the woman becomes pregnant. And our SAPAMO study actually started in 2014 when dolutegravir was not being used in Botswana, but we were actually interested in neural tube defects at the time because of a different antiretroviral, efavirenz, which had shown in preclinical studies some concern in a monkey model for CNS birth defects. So in 2014, efavirenz was part of the first-line antiretrovirals in Botswana, and so the aim of our study was to evaluate the risk of neural tube defects among women on different antiretroviral therapies. Our study is pretty straightforward. It's a birth defect surveillance. Research assistants collect information on the mothers and the babies at the time of delivery at 8 of the largest maternity sites in Botswana. That covers about 45% of all of the births in the whole country. And when a midwife who works in the hospital identifies a baby with a birth defect, she contacts our research assistants who consent the mother for a photograph of the abnormality, which is reviewed by our experts in Boston. In mid-2016, Botswana switched their first-line ART to dolutegravir, becoming the first country to do this for all adults and pregnant women. And our study was quickly able to gather data on those women who started their regimen dolutegravir during pregnancy. And we recently published data showing that it was just as safe to start dolutegravir during pregnancy as it was to start efavirenz during pregnancy. But it took us a lot longer to accrue women who started their regimen before pregnancy because they had to start their ART, then become pregnant, and then deliver to get into our surveillance. So by May of this year, we had just over 400 women with data on dolutegravir at conception, and we noticed a higher than expected number of neural tube defects in this group, close to 1 in 100 when we were expecting 1 in 1,000. So we performed this interim unplanned analysis showing that there were 4 neural tube defects among 426 women on dolutegravir at conception, a prevalence of 0.94%, compared to a prevalence of 0.12 among women on all other non-dolutegravir ART regimens at conception, 0.05 among the women on efavirenz at conception, which is what we had initially been worried about, and 0.09% among women who are HIV negative. There were no neural tube defects among the women who started their dolutegravir during pregnancy after conception. And this is what led to the safety warnings, FDA, WHO, and EMA. We've been continuing SAPAMO, and since May 1st, we've had 170 more births collected on women on dolutegravir from conception with no neural tube defects in this group. And although I think this is good, I don't think we can take much reassurance, as these are small numbers. The prevalence is still about 7 times higher than the other groups and statistically significant. But I do want to emphasize that we found is really preliminary. It's based on 4 cases with very small numbers and a very small difference in the overall prevalence. And we need more data to confirm or refute the signal. Our SAPAMO study will be continuing and reporting again after March of next year, where we hope to have about 1,200 dolutegravir conception exposures. And ultimately, I think whether this signal is confirmed or refuted, it's really highlighted a need for better access to contraception, better patient-centered care in areas with high HIV prevalence, and better systems to study the safety of antiretrovirals in pregnancy, as dolutegravir is not going to be the last HIV drug or HIV treatment that's rolled out in the future.
Great.
Thank you.
Thank you very much, Rebecca. And I just wanted, because we have put 2 at this conference, along with other sessions and symposia going on. The CCC has put together 2 specific sessions to try and address this new finding. So this afternoon from 4:30, there'll be a symposium where Rebecca will show this data just to explain. This late-breaking abstract has been contextualized within a broader symposium. We thought that was a useful thing to do. So she will be presenting at that session at 4:30, where you will also be able to hear a voice of a woman who is using and representing other women using antiretrovirals, because I think choice comes into this as well. So that will be this afternoon at 4:30. There'll also be some modeling data to again try and contextualize, as well as input from a neonatologist at that session, just again to contextualize. On Thursday at the same time, 4:30 to 6:30, we have another symposium looking at dolutegravir rollout more generally. And again, there you will hear voices of community, as well as this approach to contraception, which I think Rebecca rightly identifies as something we may need to urgently address in our practices. So look out for those symposia. They may not have got into your hard program because they came together late, but they are in your soft online program. So location, etc., is there. Tomorrow, Pedro will also be presenting a plenary on the integrase era more generally, and so I'm sure it'll come up again there. So thank you to Rebecca for doing that. Our next speaker, changing gears a little bit now and moving to cure, will be Sara Fiddler. And just to remind you all that Sara comes from Imperial College London, and she'll be discussing the results of the RIVER study. This is the first randomized controlled trial of a kick and kill strategy to reduce the viral reservoir and obviously have the ultimate goal of a functional cure. There's been lots of discussion about this strategy in recent years, and so I'm going to, without further ado, ask Sara to give us her remarks.
Thank you, and thank you for highlighting this study. We're delighted. So the RIVER trial was a proof of concept, randomized controlled cure trial. As we've just heard, it was one of the first trials that's on this scale, and it's randomized to a treatment-only arm. Our key question in the cure world is that the treatment we've heard is amazing. It's extremely good. And so whatever we do towards the cure research has got to be better than treatment on its own, and in particular, it's got to be safe. So the study was designed to compare the impact of this kick and kill approach to standard therapy, and it's powered to look at the laboratory measures of HIV reservoir, which is the key barrier to why antiretroviral therapy on its own can't cure HIV. So the kick and kill approach we used in this trial was a drug called vorinostat. This works in a non-HIV specific way, and it's called a histone deacetylase inhibitor. It's a type of drug that is usually used for people living with cancer. And the kill side of the intervention was a T-cell prime boost vaccine. We used exactly the same vaccine that has been used previously in a study from colleagues in Barcelona, which was shown to be very effective at generating T-cells to HIV and safe. We enrolled 60 individuals with very recently acquired HIV infection, and we deliberately chose individuals with recent infection because we know that the reservoir size is the smallest in that situation, and they have a strong and preserved immune response. We had the most exceptional engagement and commitment from our study participants. Nobody dropped out of this study, and every participant contributed data to the primary endpoint, making the result very robust. We saw no difference between the two study arms. So when we look at our total HIV DNA in CD4 T cells at week 16 and week 18 combined data after randomization, although there was a significant drop in total DNA compared to when people were enrolled into the study prior to starting therapy, there was no difference in these measures between the two arms. Importantly, we saw no evidence of harm. The interventions appeared to be safe, were well tolerated, and only 2 people didn't take every single dose of the intervention. Of course, the overall effect wasn't what we would hope for, but it was definitive. All results move the knowledge forward, even if they're somewhat disappointing. The component parts of this study seem to work as we'd expected. So vorinostat did inhibit histone deacetylation, And the vaccines we've shown induce potent HIV-specific CD4 and CD8 T-cell responses, as well as showing inhibition in a viral inhibition assay of viral replication. The immune responses we saw in the patients who'd been vaccinated were significantly better than those people who just had treatment on their own. So in summary, I think trials like RIVER are really necessary to move the field forward. We've learned a lot over the last 25 years of the AIDS epidemic in combining our knowledge and learning as we go. And I hope that the data we get from this trial will really inform the design of future research, and we're continuing to work towards a cure. Thank you.
Thanks, Sarah. And really also to help contextualize where we are with cure research, we've asked Sharon Lewin to join us on the panel today. Sharon is director of the Peter Doherty Institute for Infection and Immunity in Melbourne, Australia, well known for her role on the Cure initiative of the IS. She's also happily on the Scientific Program Committee for AIDS 2018, especially in light of the RIVER study results. I've asked Sharon just to contextualize where we are at this moment.
Thanks, Linda Gale. So I thought I'd start by saying a cure remains a top scientific priority for the scientific and broader community. We've heard a lot about the costs and significant challenges around sustained antiretroviral therapy. A cure will be one way that we may be able to avoid that. What do I mean by a cure? It effectively means being able to stop antiretroviral therapy and the virus staying at low levels, not causing any adverse events for the person and not being able to be transmitted. So what we've learnt, I think, over the last decade and from the RIVER study that you just heard about is that this is going to be a very difficult scientific challenge in order to eradicate HIV and allow people to safely stop treatment. But as you again heard from Sarah, we need to keep trying using an informed and strategically based on good scientific data of what we move into the clinic. RIVER is a really important study in the field because it is one of the largest study of a cure intervention specifically related to kick and kill. It was randomised, and it was also done in people who started treatment early, within 6 months of infection. And in those individuals, we know that the reservoir is smaller and immune function tends to be better as well. However, these combination studies take a long time. So I think RIVER was designed really, it's taken about 4 years to complete. And this is a necessary part of combination studies. We first need to know that each intervention is safe on its own, and then to see what we get when we put the two interventions together. As you heard, vorinostat was used as a kick agent. I would call it a first-generation kick agent, which was what we were using in 2014, and there have been some significant advances about other agents to choose. However, that just highlights the complexity of doing these combination studies. We have said for a while that I think a combination approach will be needed, largely to reduce the amount of virus that persists in people on treatment and also to boost the immune system. And we're certainly seeing encouraging results in some monkey studies using this approach with a different activating agent, but those studies are yet to be translated into human clinical trials. I think what you'll see at the conference and the other abstracts are under embargo is quite a lot of basic science, which I think needs to be a top priority, understanding still where the virus hides, how it persists on treatment, and new strategies to tackle it. There are still lots of unknowns that we're uncovering, and you'll hear about that at the conference, particularly the role of where virus hides in tissue and how best to measure the virus. Finally, I just wanted to highlight that, as all of you know, 80% of people living with HIV are in sub-Saharan Africa, and sub-Saharan Africa and low-income countries do have a very important role to play in cure research. There are many clinical trials now happening, largely focusing on cure in babies and in women, and these are happening in low-income countries. And as part of the IS initiative, we're going to continue a significant effort to raise literacy and capacity building and cure research in those settings, which I think will be critical in advancing the agenda. Thank you.
Thank you, Sharon. Great. So that concludes our lineup. Very happy to take questions. Again, for those of you who haven't been here yet, we go to the mic, please. If you could just say your name and where you're from and direct your question to an individual and keep your questions quite short. That'll be appreciated. We'll start with yourself. Thank you.
Yeah, hi. Jeff Berry, Positively Rare Magazine. This question is for the three dolutegravir presenters. I'll keep it short there. Simplification obviously is very important for reasons around toxicity as well as access and cost. And I wondered if you could speak to the significance of having 3TC on board and M184V mutation, as well as, there's another part of that question, but if you could speak to that.
I'll ask Pedro to pick that up.
Oh, the other question was, there's a study here around dolutegravir monotherapy.
Okay, thank you for your question. First of all, I didn't say, but I think it's a very important point, we didn't see any resistance, neither in the integrase enzyme nor in the reverse transcriptase enzyme in our study. Second, the choice of 3TC is because we learned from other studies that you need to inhibit the reverse transcriptase enzyme in order to be successful when you combine with a potent agent. 3TC is a very well tolerated drug. It's lacking any kind of drug-drug interactions. Is active, and it could have selected M184V. This was one of the open questions that we had at the beginning of the trial, but fortunately enough, we didn't see any single case of confirmed virological withdrawal in which M184V was selected.
Great. We'll go to Kerry and then Michael. So Kerry?
Kerry Cullinan from Healthy News South Africa. I've got two questions, if I may. The first is also linked to resistance using the two drugs. We've always been told that we have to have three drugs, so it's a bit scary to think of moving to two drugs. And what would the resistance profile be over the longer term, because this is maybe quite a short study. And then moving on to the Botswana study. Activists have been protesting, saying that the WHO has jumped the gun and that dolutegravir is very well tolerated, and that women should be given choice and should be encouraged to use contraception while they're on dolutegravir. What would your response be to that? Thanks.
Great. I'll ask Pedro to, is that okay? And then Rebecca.
Yeah. First of all, regarding, I missed a response from the first gentleman. Monotherapy so far has shown not to be recommended. In fact, most of the study with monotherapy with dolutegravir ended up with a given amount of failure, but the most concerning issue is that they selected for resistance. So monotherapy should not be recommended. As much as we are very confident with dual therapy with 3TC, monotherapy should not be recommended. Regarding the durability of the study, this is an open question, and that's the reason why the study was designed to be for patients to be followed in the double-blind randomization period for 144 weeks. So as of today, we can say that at 48 weeks, it's safe, it's effective, it's non-inferior. And we will see, as time goes by, if this is confirmed in the long run. Rebecca?
Sure. I think after the warnings came out in May, many people interpreted that as WHO and others saying that women shouldn't be on dolutegravir. But I think as things have evolved, and at the WHO recent guidelines update that they were talking about yesterday, it's quite clear that they also agree with the activists that this should be not a one-size-fits-all kind of approach, that individual women have very different needs. Some want to become pregnant, some don't want to become pregnant, and there's lots in the middle. So I think that the activists are right, and I think that everybody is really on their side. And then the question becomes, how do we make that a reality on the ground? How do we get people the contraceptive access that they need and allow them to make an informed choice about going on these regimens with the data that's out there that is, again, very preliminary.
Thanks, Rebecca. Going to microphone
Michael
two.
Smith, MedPage today. Just a follow-up for Dr. Khan, if I may. So now we have an effective two-drug regimen. I don't know what the regulatory position is, but would you, in your practice, and would you recommend other doctors in their practices start thinking about using the dolutegravir 3TC combination?
Of course, provided that the patients fit the same inclusion criteria that we had in our trial. That means less than 500,000 copies, no baseline genotype resistance, and no HBV infection. I would be very comfortable using this as an optional strategy. I don't think that we have, again, I will use the same words, not one size fits all. So I don't think that everybody should be treated with this combination, but I think this gives us a very safe and potent combination with less drug burden for our patients.
Thank you.
Maria?
Thank you. Marie Leroux, I'm sorry, with the Agence France Presse. I have a question, please, for Mariana. Considering the results from the Botswana study, do you think that in any way challenges the decision of the ministry and your government to switch to dolutegravir as a first-line drug? And specifically, obviously, when it comes to women wishing to start a family, and should there perhaps be special recommendations for such women? Thank you.
Yes, there have been. Soon after the WHO released these recommendations, we did so as well in Brazil. There's actually going to be, I think on Thursday, the 26th, a press conference with our director who's here, and she's going to discuss that a little bit. So we've changed the recommendations, similar to what WHO released yesterday. So women should only be on dolutegravir given that they have effective contraception. And we're also implementing a surveillance study to try to follow up on women who took dolutegravir during conception. So you'll hear more about that later, but we already have the results for, I think, around 160 women, and no cases of neurotube disorders have been found.
Yeah, so obviously I think just to contextualize, we're scanning the world to see how we can gather more of this data to feed into the decisions that need to be made. So thank you, Marianne. Right, Mike 1.
Lala Lopez Gonzalez with the Beccacisa Center for Health Journalism. My question is for Pedro. What do you think are the next steps in terms of studies that we need to move this to like a more generalizable, more usable regimen?
Well, in regards to this study, is your question? As I said, we will follow our patients at least at week 144, and so we will confirm, hopefully, the durability of this regimen. This is the main plan that we have. I know that some people are looking to other two-drug combinations following the path that started with the Gardel study and afterwards with the UNDE study, the PADL study, the ACTC 53, and now with Gemini. So any new study that would come would be very welcome to confirm that the two-drug approach could be as good as a three-drug approach given the conditions of the patients. No?
Microphone 2, and then Heather.
Paul Ben-Kimon with Le Monde. My question is for Rebecca Zash. You gave figures for the different groups of children, and but I just want to clarify one point. When you give the figure for any antiviral therapy without dolutegravir, does that include or not the one with efavirenz?
That does include the one with efavirenz. So that group is 11,300 on any other ART, including efavirenz, and then of those, about 5,700 are efavirenz.
Good. Heather?
Hi. Hi, this is Heather Berner from Medscape Medical News. And Dr. Fiddler, I wanted to ask you, I find cure research really confusing, so please excuse if this is a real basic question, but you called this the River study a proof of concept, and so since it wasn't able to clear the reservoir, does that mean the concept hasn't been proven? Can you talk a little bit about what you say we need to learn from this, but tell me what we need to learn from this, what the next step is, how to incorporate this into future research. Thank you.
Thanks, good question. So the cure problem, just to sort of simplify the strategy, is to remove the reservoir cells or eliminate them to such a low level that the body can contain virus without treatment, and that's what we call remission. And the proof of concept is a translation of some of the previous work, as Sharon mentioned. So there has been studies using the drug that we use to activate the virus, the vorinostat, on its own with antiretroviral therapy. And there have also been studies, as I mentioned, the Barcelona group did, using the vaccine on their own in addition to antiretrovirals. So our study put those together. So there are various different concepts about questions about what we're trying to look at here. If we put those two together in humans with current sort of potency of antiretroviral therapy, are they better than treatment? And that was the concept we were trying to prove. However, because it didn't show one of the primary endpoints that we've presented so far, it doesn't necessarily mean that these people are not in remission, and it doesn't necessarily mean the concept is incorrect. All I can say, just to be sort of detailed here, is that for the people in our trial who had those two combinations of that particular kick drug with that particular vaccine, it didn't look like it made a difference to what are surrogate measures of the reservoir. We did not interrupt therapy in our patients. And that, at the moment, is controversial, but it is really the only way we currently really have to say, does this translate into a realistic remission for our people living with HIV? Now, in our trial, we didn't design to interrupt treatment, and it may be something that we consider doing in a later stage. I certainly don't think that I want people to take away from this that the kick and kill approach does not work, but we, I think, have shown that using the two interventions in this trial, that didn't work.
So we don't know if patients are in remission?
We don't know if they're in remission according to the definition that they haven't stopped treatment and viruses come back. These are the data we have at the moment is all laboratory measures of reservoir, which is, of course, different.
Microphone one.
Simon Collins from HIV iBase. I've got two quick questions. One is to Linda Gale. It's the same question as in the previous press conference. It's really just a statement that it's impossible for us to report these really tentatively exciting studies without having full access to the presentations. And where presenters are presenting commercially sensitive information relating to drugs, then it's really uncomfortable that the top-line results will be presented before we have full access to the data. And then I've got a question for Pedro, because I haven't been able to see your slides. Is there a difference? Will you be presenting the stratified results for higher and lower viral load and full demographics for viral load at study entry, and whether the side effect differences that you reported in favour of the dual therapy arm are statistically significant?
So the first part of your question, could you repeat it, please?
The first part was... will you report by stratification higher viral load?
Okay, yes, we stratified our patients for viral load and for CD4s, below and above 100,000 copies and below and above 200 CD4s. So regarding your particular question about viral load, what I can tell is that there was no difference in the high viral load strata, which is really the stress test for any combination that you want to test for, right?
Yep.
And second one was?
I think that's it.
Were the differences in side effects that you reported in the abstract, are they statistically significant?
We saw in the overall list of side effects, we saw less side effects in the dual therapy arm, but I mean the difference was not significant.
Okay.
Where we saw significant difference was in renal biomarkers and also in bone health markers.
So thank you. I look forward to the presentation.
Okay, thank you.
Thank you. Number two.
Mitchell Zoller, Internal Medicine News. A question for either Dr. Zash or somebody else on the panel. I'm wondering if either there's evidence for or if there's any suspicion of folic acid supplement might mitigate the neural tube defect effect.
I think that's a question that's come up a lot. It's important to know that in Botswana, they don't fortify grains with folate, which does occur in other countries like the United States. And women in our study are almost never on folate supplementation before they fall pregnant, so there may be a higher risk there. People are looking into this question actively. It would be great if that were true. I think if you look at some other drugs that cause neural tube defects, not in HIV class, folate supplementation does not help mitigate, so we really don't know at this point.
Great. Seeing no more questions then, I thank you all for being present at this first of our treatment press conferences. And Cure, not to forget Cure. Thank you very much to the panel for, I think, bringing your science to AIDS 2018 and being present today. We really appreciate it. And I wish you all well, and we'll see you at the next press conference. Thank you.